This is the Common Health Podcast, a product of the CSIS Bipartisan Alliance for Global Health Security. We engage with diverse leaders on the question of how best to navigate this period of exceptional turmoil, reform, and uncertainty in U.S. leadership. We are aided throughout by our able producer, Marla Hiller. I'm delighted today to be joined by Dr. Tom Frieden, CEO and founder of Resolve to Save Lives, former director of the Centers for Disease Control and Prevention, CDC, 2009 through January 20th, 2017. Prior to that, was the director of international health programs for Bloomberg Philanthropies and health commissioner, City of New York. And prior to that, 5 years working on tuberculosis in India. Tom, thanks so much for making time to be with us here today.
Thank you, Steve. Great to speak with you.
Now, you've been writing and speaking quite a bit as the second Trump administration has landed and begun its work. And what we wanted to do today was try to get your reflections on how some of these changes are unfolding and what they mean. And we're going to break it into a couple of different parts and policies. Let's start first with CDC. And what do we know in terms of the changes that have been enacted there in terms of RIFs, layoffs, elimination of programs and offices? How do we understand the radical transparency of change that's underway at CDC right now? I was in Atlanta last week, right after many of these changes were announced. I must say it was a sobering moment to be in Atlanta, visiting and talking to people. It was a very somber town, as you might expect. There were protests in support of CDC, but it was a very quiet and sad place, I must say. It left a very deep impression on me being there for 2 days. I was there for 2 full days. So over to you, Tom. Give us a quick overview of what has happened at CDC in this period.
Well, Steve, the bottom line is that recent changes make Americans less safe and less likely to reverse the increase in chronic disease. CDC has been the flagship of public health for generations. It's worked 24/7 to protect Americans from threats, and right now, it can't do that nearly as well. And a weaker CDC means a sicker America. These are cuts that are not going to be efficient. Stopping programs that work doesn't make government more efficient. It costs lives, increases healthcare costs, and weakens our economy if they're not reversed.
Now, I'd like to hone in on some of the specifics. You've said this is a recipe for disaster. I think what you mean by that is we are giving up capabilities that will come back to haunt us in a variety of ways. We know that the tobacco program, which you've labeled as a gift to big tobacco, has been decimated. We know that HIV prevention, even though infectious diseases are supposed to become a greater focus of work within CDC, HIV prevention has been, that entire branch seems to have been eliminated. And there's several other areas in which CDC programmatic capabilities have been scaled back or eliminated. Can you just walk us through?
There is so much damage, it's hard to summarize, but let me give you 3 examples. The first is tobacco control. Shutting CDC's tobacco control program blinds us to the tactics of big tobacco. It endangers our kids, and it's going to increase tobacco use, cancer, heart disease, healthcare costs, and preventable suffering and death. The only winners here are big tobacco and cancer cells. This was a successful program. The number of high school students who smoke has been falling dramatically since 2019. Vaping exploded, and it was CDC studies that documented that. 28% of kids were vaping in 2019, still too high, but down to 8% last year. Smoking in teens, down from 36% in 1997 to less than 4% last year. The tobacco industry has been trying to close this program for decades. The current administration accomplished that in weeks. And this includes, and this is something many people don't realize, about 2/3 or more of all of the dollars that go to CDC get sent out to states. Kansas, West Virginia, Georgia, Michigan, they're losing about half of all of their tobacco prevention funding money. Some people have said, oh, well, FDA does tobacco, so CDC doesn't need to. FDA regulates products. CDC protects people. There's no other part of the federal government that tracks tobacco use the way CDC does, that supports comprehensive tobacco control programs in communities, or that tracks what the tobacco industry is doing and its influence and impact in people. So if the secretary wants to take on chronic diseases, well, tobacco is still the #1 cause of chronic disease in the US, and he's just hamstrung that, not just at CDC, but at FDA also, where very talented director of the tobacco products there was let go. Second broad area has to do with environmental health. They just eliminated the program that works on nanoparticles and microplastics and endocrine disruptors and asthma and soot, PM2.5. Yes, these are real problems, but we're now flying blind to them and to the ability to track the harms and to reverse them.
So this is all about chemical toxicities.
Yes.
In work environments, in home, in drinking water. It covers hundreds of different molecules, right?
Absolutely. They've left the lab largely intact so far, apparently, but a lab without a program to figure out what specimens to send and how to interpret them and what action to take doesn't do much good. Chronic disease is not a big mystery. The 5 major drivers of it are tobacco, salt, sugar, soot, or PM2.5, and alcohol. The big difference between infectious diseases and non-infectious diseases is that non-infectious diseases don't hire lobbyists. The tobacco company, junk food companies, the alcohol industry, and polluters hire lobbyists, and therefore it's very hard to make progress on chronic disease. The answer is not to divorce the expertise in chronic disease from CDC's laboratories and tracking systems and program systems and support to states. The way forward on chronic disease is to implement what we know works and then to study the other stuff to figure out what more we need to do. But I was saying there are 3 broad areas. I've mentioned tobacco, I mentioned the environmental toxicities. The third is maybe a little harder to realize just how deep and broad the damage will be. It has to do with communication. They basically eliminated all of the communication offices throughout CDC. That means less information and less reliable information for Americans to decide and to protect themselves. Look, American taxpayers pay for CDC's specialists, and they have the right, we have the right, to hear directly from them without interference by politicians. Eliminating communication staff means we all have less information on how to protect ourselves from health threats. Let me give you 2 examples. If you want to go to anywhere in the world, you or your doctor will check the CDC website to see what diseases are spreading there and what are the preventive measures. I don't know how that site is going to be maintained. There's no one to maintain the CDC website anymore. Second example, if there's an outbreak, where are you going to go for information? CDC website. Who's going to put that there? Well, there are no communication staff to do that anymore. In addition, CDC communications programs don't just talk, they listen. They run something called CDC Info that gets thousands and thousands of calls from the public. That's important, not just as a public service, it's also important as a pulse to see what are people concerned about, what are they asking about, what wasn't clear in our communications. Moving all of that to a political appointee in Washington and creating a new bureaucracy to deal with it, well, I just hope Congress and the thinking that they're doing on how to do this well and efficiently gets started and gets listened to, because of course it's possible to be more efficient and more effective. But our biggest problems haven't been that we've overinvested in addressing chronic diseases. Our biggest problems have been that the lobbyists have blocked us and that our healthcare system does such a bad job of preventing disease. Steve, we spend less than 5% of our total Medicare budget on primary care. And the best evidence is if we tripled that percentage, we would reduce overall healthcare spending. Primary care is that important if we do it right.
On the communication side, 2 questions. One is, what happens to the famous iconic MMWR, the Morbidity Mortality Weekly Report? What happens to that? And secondly, eliminating the communications capabilities is part of a larger plan in which communications is going to be consolidated in the office of the secretary, it seems to me. So comment on those 2 questions, please.
Well, just to start with the second one of the mistakes that the Biden administration made, in my view, was requiring CDC to speak from the White House. That meant that if you didn't agree with the White House, you weren't going to listen to what CDC said. And we see that in the partisan divide in confidence in CDC. It's really important that we get our medical advice from medical practitioners, not from politicians. And putting communications under Secretary Kennedy or any health secretary really risks that. So far, what we've seen is after a pause, the MMWR has come back. That's good. And it's had good articles in it. But the MMWR isn't just a scientific publication. It is a suite of activities, including something called Vital Signs, which relies heavily on a communications office that no longer exists.
Now, the dissolution of ASPR and the transfer of the Strategic National Stockpile to CDC, what does that mean?
Well, actually, CDC used to manage the national stockpile and can do it again quite readily. There are a lot of political pressures on what to buy to put in that stockpile, and there's tough decisions that need to be made. Those should be made, in my view, based on how much money you have and what that money can do to best protect Americans. And that includes an end-to-end approach. So if we buy something, it's not just going to be sitting in a warehouse, but if we do have an emergency, it can be used efficiently. So I do think there can be benefits for moving the Strategic National Stockpile back to CDC, where it was for many years before. But the broader risk here is this idea that CDC should only handle infectious diseases. And this really is the result of a misconception. This idea that, CDC messed up in COVID because it was involved in these, extraneous issues. And if it only focuses on infectious diseases, it'll do a better job and protect Americans better. That's mistaken in just about every aspect of its analysis. First off, CDC was silenced from February of 2020 for the rest of 2020. And that's the critical time at which the response was needed, at which CDC advice was ignored. Of course, CDC did make mistakes, most prominently the laboratory mistake that really did result in explosive and preventable spread of COVID in New York City and elsewhere. But the fact is that CDC has worked 24/7 to protect Americans from threats, whether infectious or non-infectious, whether natural or man-made, whether from the US or anywhere in the world. And now, with these changes, the CDC can no longer protect the US from non-infectious diseases or non-US threats. Outbreaks don't come with labels. Public health emergencies blur the line between infectious and non-infectious. Look at Zika. It caused birth defects, and we had to involve our reproductive health program, our environmental health program, our vector control program, our laboratories, and more. Toxic shock syndrome, or vaping-related lung injuries, or environmental contamination, they all require both infectious disease and other expertise. CDC has provided an integrated response. Fragmenting that is going to cost us time and lives. And globally, with the US abrupt pullout from global health programs, we have a much greater risk of drug-resistant tuberculosis and polio and measles coming to the US, and globally, many, many more deaths from measles and malaria and tuberculosis and HIV. This is a disaster for global health, and the US will not be immune to the harms.
Say a bit more about the global health dimension of this. Now, the Global Health Center has been dissolved.
No, the CDC's global health program has not been dissolved. It is largely or almost exclusively on infectious diseases, but other parts of the US government have been abruptly shut. And that includes things like our support for Gavi, the vaccine alliance that has prevented more than 15 million deaths around the world. The fewer infectious disease outbreaks there are around the world, the safer Americans are. It's safer, it's cheaper, it's quicker, it's more effective to stop health threats when and where they emerge, rather than having to fight them here within the United States. The USAID programs on global health security, on malaria, supporting immunization, supporting polio, were all stopped overnight. All of those programs are really suffering globally. And that's not just something that will kill millions of people around the world. That will also make it much riskier in the US.
Why do you think CDC and AID were so vulnerable? What explains the lack of response, the ability of the Trump White House to go in and enact these swift, radical, ferocious changes, which don't seem to have much in the way of a real strategy behind them. They're vengeful, they're swift, they're somewhat nihilistic in character. But what is it that explains the exceptional vulnerability, lack of public response to what has happened?
Well, there's a lot packed into that question, Steve. I think, first off, when I was in the federal government, we were informed that if Congress passed a budget, it was a violation of the law not to implement that budget. But the current administration believes that that is not the law, and so is not implementing programs that are congressionally authorized, mandated, and funded. That's unprecedented, at least since the Nixon administration. This has not happened. And there's so much happening that I think it's challenging to marshal much of a response. And it's so hard to see the impacts because some of them are very apparent. So when Secretary Kennedy said, oh, we made a mistake, we eliminated the lead poisoning prevention program and we didn't mean to, well, yeah, we have lead poisoning events all over the US that the CDC can no longer respond to. So they've understood that. But there are many other programs that are being cut that you won't immediately see the results of. And that, I think, is the fundamental problem advocating for public health.
What about the fact that such a large portion of the public is skeptical of AID and CDC and willing to sort of, what is it that happened that we have such a deep skepticism of these institutions?
Well, I think you have to keep them separate. Let's leave USAID aside for a minute. And in terms of CDC, one of the challenges is that when public health succeeds, nobody notices.
Yeah.
Nobody woke up this morning and said, oh, thank goodness I didn't die of smallpox yesterday. Well, smallpox killed hundreds of millions of people. We don't have to worry about it. We don't have to vaccinate against it because it's been eradicated from the world that CDC led. So there are a lot of things that are done that people just don't see about what CDC does. To get theoretical here, it's something called the prevention paradox that Jeffrey Rose described, that programs that help a lot of people a little bit do a lot more good than programs that help a few people a lot. So to give you an example of that, in the US, if we have a new hospital and they do great work preventing people from dying once they've had a heart attack, that's really exciting. It's dramatic. But if we eliminate artificial trans fat, as we did in the US under both the Obama and Trump administrations, if we eliminate trans fat, we prevent hundreds of thousands of heart attacks, but not a single person who didn't have a heart attack will ever know that their life was saved by that measure.
Thank you. Let's talk a bit about Secretary Kennedy and his plan that's emerging. It looks to me that the Administration for a Healthy America, AHA, which is going to be run out of the Secretary's office, is going to become a central feature of HHS. And BARDA is being transferred there, SAMHSA is being transferred there. There's a centralization around communications, procurement, HR, and the like. And this very big emphasis on chronic diseases, quality of food, changing of habits. And you've written about that. Let's start with, how do you see this AHA emerging as a dominant feature of HHS in this next period?
Well, of course, it's possible for organizations to be more efficient, but taking a chainsaw to public health, firing thousands of people who've spent decades learning how to track and stop chronic diseases is not the right way to do it. What we're seeing now is abrupt. It's reorganizing the deck chairs and tossing out lifetimes of experience. It's not a thoughtful way to do this. And before, there was thought in Congress about looking at the CDC role, looking at the whole HHS ecosystem and how it could be modernized and reformed. But blowing it up is not likely to make it better. It's not going to protect Americans from toxins and tobacco. It's likely to worsen the crisis. And the way they're doing it is not efficient. It's wasteful. And it's going to lead to worse outcomes that, given the interconnected nature of infectious and non-infectious diseases, will make us less safe. And the fact that they're undermining successful programs will increase healthcare costs. Let me mention two things where I think there could be benefit from better coordination. One of them has to do with primary health care. Primary health care is massively underinvested in this country. And the survey data suggests there are 100 million Americans that don't have a primary care provider, don't have a family doctor. That's disgraceful. We spend nearly $5 trillion on healthcare. It's nearly one out of every $5 in our economy, and we get terrible results. That's not a public health failure. That's a healthcare system failure. The public health system is a small rounding error on what we spend on healthcare in this country. If we really invest in primary care and focus on things like controlling high blood pressure, we can prevent a huge number of heart attacks, strokes, disability, dementia, kidney failure, and death. So yes, there is something more we could do, but that means changing the financial incentives within the Center for Medicare and Medicaid Services and in private insurance as well. We also could do more on what we study in chronic disease. I think you have to really put things in two different buckets. One of them is we know what to do, we just need to get it done. And that includes things like taxing tobacco, alcohol, soda, and junk food. It means stopping the agricultural subsidies on unhealthy foods that make unhealthy foods cheaper than healthy foods. It means not buying unhealthy stuff with public dollars, whether in schools or elsewhere. But there are some things that we don't understand. For example, cancer has been increasing in young people in this country, and we don't know why. It's likely to be a toxin. It may well be something in our food. We have these three broad areas where we're just beginning to understand the huge potential risks: microplastics, nanoparticles, and endocrine disruptors. They're separate, there's some overlap among them, but yes, these are real risks. They're not what's driving most of the chronic diseases. What's driving most of the chronic diseases is well known. So what NIH could do as part of this would be to study the things we don't know, and also to study, if they're going to study things that we already know, what's preventing the implementation and what's a good implementation of those programs, whether it's improving blood pressure control or improving nutrition to reduce hypertension.
Say a few words about the approach to the measles outbreak in Texas, New Mexico. It's now Kansas and Oklahoma. We're seeing some ignition of outbreaks in other under-vaccinated communities that may be tied to the Mennonite populations. And there's a certain hazard that this kindling, as the numbers have dropped across the country, and particularly amongst special communities that don't vaccinate their children, that we're on the edge of something quite big. What's your thought on that, and how have you viewed the response up to now? We've had another child die in the last few days. We had the secretary go to the funeral in the last few days and issue a statement that was a call for vaccination, but it was mixed in with a bunch of other things too.
Steve, I began as an epidemic intelligence service officer working on a large measles outbreak in New York City in the early 90s. Measles is probably the most infectious of all infectious diseases, and it is not a benign illness. Before there was measles vaccination, in years when there were measles outbreaks, there were millions of cases, tens of thousands of hospitalizations, thousands of kids who were disabled for life with blindness, deafness, brain problems, and hundreds of kids who died. What we've seen is the harms of misinformation. Secretary Kennedy continues to say things that are not factual. The measles vaccine is safe and effective. He said that every year people die from measles vaccine. That is false. It is untrue. He also says things that are very misleading. He says, oh, whether or not you vaccinate should be a personal choice. Well, it's always an informed decision. Everyone who gets a vaccination in the US has to sign, or their parent or guardian has to sign informed consent and have to be given a very detailed vaccine information statement on the risks and benefits. But whether or not you get vaccinated doesn't just affect you, it also affects your community. That kid down the block who has leukemia and may die if your kid doesn't get vaccinated. So vaccination is absolutely a decision that individuals need to take, but it's also a decision that has community ramification. Secretary Kennedy has also been encouraging vitamin A and cod liver oil. Now, actually go back to this in the early 90s, I did the study that showed that vitamin A levels were low in US kids who had measles. It wasn't known before. That doesn't mean that vitamin A will prevent measles. It won't. That doesn't mean that vitamin A taken before you have measles results in any improvement of outcomes. It's not likely to. What it does mean is that if you happen to be a young infant, like 2 years old, then 2 very specific doses of vitamin A supplements, one day apart, can slightly reduce your fever and your illness. But the way to protect people from measles is to vaccinate. And vitamin A, if given too much, can cause serious problems. So we're seeing toxic information leading to toxic results in people.
Where is this going to go, do you think, this measles outbreak?
Well, measles does not stop on its own. It's really good at finding any weakness in a community, any unvaccinated people. You can't stop a measles outbreak without measles vaccination. You can't stop a measles outbreak without good old-fashioned public health work, tracking down individuals, speaking with communities, delivering vaccines in a way that's acceptable to people. So already, Steve, we have had the second largest outbreak of measles in the last 25 years. We've had as many deaths from measles as in the last 25 years combined in the US, and it's still gaining steam in many of the clusters.
Thank you. Tom, we're getting towards the end of our time here this morning. I want to end on a positive note. We ask all of our guests to close by talking about where you see some light in this picture. This is a dark picture we're in right now. Where do you find optimism and hope in this period?
This is a really dark time. And there are thousands of people who have devoted their life to public health, who have suddenly, without warning, without rationale, without adequate thought, been let go. There are programs that have been closed, and the implications are quite serious for the US and for global health. I don't think there's a silver lining here, but I do think there's hope. I think there's hope because we do have exciting new tools, new ways of detecting, treating, preventing disease, new ways of collaborating, new ways even of using artificial intelligence to be faster and smarter and better and more efficient. And ultimately, I'm given confidence and hope by the healthcare workers, the doctors, the nurses, the public health specialists who remain committed to working around the clock to protect people from threats, to figuring out what's harming people and to stopping those harms. And that commitment doesn't change, even when government does things that are not sensible.
Tom, thank you so much for everything you do, for your leadership and your voice in this moment, and for taking the time to be with us today. Very grateful.
Thank you, Steve. Always a pleasure speaking with you.
Thank you for listening to The Common Health. If you enjoyed this podcast, please give us a follow and leave a review. To learn more about the CSIS Bipartisan Alliance for Global Health Security or listen to other CSIS podcasts, please visit csis.org.